So good morning, everybody. My name's Andrew Hopper. I'm a gastroenterology consultant at Sheffield, and I suppose my remit that I was asked for is to talk about esophageal cancer and the, let's put a slide up, and the, I suppose our relationship with primary care and trying to, I suppose, improve the outcomes for, I suppose, upper GI cancer, but really mainly I keep sliding towards esophageal cancer because of the complexities of the pathway. Now, I'm very grateful for Kumar doing a lot of the talk for me, so I'll hopefully try and move things forward for everybody. So, planning is everything. There was a 10-year plan when the NHS was 70 in 2018, and there was going to launch a big plan and took a big public service, I suppose, questionnaire to representations made with the public, and they wanted to just see the vision for the next 10 years before the NHS was going to be 80. So a lot of dramatic plans and costing and everything was arranged, and especially concentrating on numerous aspects of the National Health Service, but cancer was obviously one of them. And obviously subject to change with our friend COVID coming along, things went a little bit to pot. But just before that happened, we were trying to improve the services for esophageal cancer, because unfortunately, as already been highlighted already, gastric and esophageal cancer is one of the bad ones. We're talking less than 50% 1 year survival in all comers, and despite numerous efforts as scoping, as Kumar's already said, over 15,000 people a year, we are really trying to battle against what is a disease of relentless problem, which we're trying to combat again. So it was highlighted as one of the big cancers that we need to improve our services for. There's obviously lung down there, and my other part of my job is dealing with pancreatic cancer, but we'll not talk about that today. So one thing that was highlighted was that the esophageal and gastric cancer pathways are one of the most complex pathways that a patient embarks upon when you do find one. So when we're dealing with esophageal cancer, is that we're really just trying to help a patient get through that journey. And also what's really been highlighted is trying to help organise their diagnosis as well. And that's why this 3162 sort of concept, or this cancer pathway is being, I suppose, rebranded from NHS England and the Cancer Alliances as a faster diagnostic service rather than a cancer pathway. So we all know that esophageal cancer is better if you, like all cancers, if you treat it earlier. So we can catch this at a mucosal disease, or if it's 80%. As soon as it gets into the areas around the esophagus, it starts going into the esophageal wall, your mortality over 5 years plummets. So that's really when we want to start catching the disease. Now, we've already talked about red flag symptoms, and I'm sure that anybody online around Sheffield or in the country has a similar sort of two-way pathway referral form, which Kumar's already been through. And that's an electronic referral now. Paper's gone. Paper takes time. Faxes take time. So this appears as soon as you press ping from the consultation. This appears in an inbox now in I suppose in an admin cancer referral inbox, and it's acted on straight away. The symptoms that Kumar's talked about is already present, and they will usually get triaged straight through to an endoscopy. And there's numerous questions on these sheets now just to make sure that the patients know that they're going to get this endoscopy quite soon, and are they coming? I won't talk about the differential, but the obviously we're looking for cancer. There's numerous diagnoses which Kumar's just spoke about. If they do get a cancer or a suspected cancer diagnosis now, is that they were requested a CT scan. We have the ability to do the scan the same day. The problem with CT is usually reporting. Our scanners are going at 24/7. They're just, there's steam coming off them. The problem is actually trying to look at the 1,026 images that get generated from a portal venous CT, chest, abdomen, and pelvis. But but if patients do get diagnosed, we can get usually a CT, and the idea is really to have same-day CT. That usually gets changed to 2 or 3 days, and that's why we really have to make sure people have had renal function checked before they attend, so they can make sure they have can get a CT scan done straight away. And at that point, they go through to an MDT. Well, obviously, it's a patient-centred MDT. And the staging and assessment is difficult because, sadly, if we wait for dysphagia, it usually means that an esophageal cancer is advanced. It's caused evasion of the esophageal wall, preventing the elasticity, preventing the swallowing sort of mechanisms. So they are looking at surgery, and the problem with esophageal surgery is, even gastric surgery as well, is that it comes with a cost, and the high 30-day mortality of patients who have already been through an assessment that's a fitness for localized disease is, you're talking between 3% and 4%, and that includes total gastrectomy as well. It has a significant mortality. So to make sure that's the case, we want to make sure we're not operating on the wrong people. So they have a diagnosis, as we've talked about. They have their CT scan. They hit an MDT to make sure they haven't got metastatic disease, and then the patient's informed of their decision, their health assessment, and then we plan some treatment. And that depends on their fitness and also then a PET CT scan, because PET CT scans will change the diagnosis in about 15% of patients. If there is a concern about nodal disease, they will then go for an endoscopic ultrasound scan. And as you can see, this is a very complex pathway which takes time. It's concerning, it's multiple attendances, it's a great stress for the patients. If it's gastric cancer, they also need a diagnostic laparoscopy because, again, that can cause, they find nodal metastases as well. So all these things need done before they're committed to that significant surgery that we're talking about. So as you can see, a complex pathway has been described. So PET scans we've talked about, assessment and staging we've talked about. So this is what we call the faster diagnostics. This faster diagnosis is a concept where there's that initial stages just need to be pushed through because of the complexities. As if there's cancer there, people need to get on board with it as soon as possible. So the idea now as well in this 3162 sort of, well, you've got 31 days before you can, you just need to know about this in 31 days and get some tests done in that time. There's more there's more targets hit within the first few days. So for example, at day 0, when primary care is concerned about the patient with dysphagia, for example, and presses the button, that goes straight through to our admin team now, who will then request and triage that on day 0 now. We've compressed our pathway down so they will actually go straight through to a gastroscopy. For example, if it's been written on the form that the patient feels too unwell or it needs a medical outpatient appointment, they'll request that MOP at that point. So the request goes through for the gastroscopy at that point. At the idea, then they get to see a gastroscopy, and the reason we really like gastroscopy is they see a clinician at the same time. So if they, as Kumar mentioned on the last talk, if they have reflux and weight loss, they know that although they're not sure what's going on, the CT can be requested at the time, so they can act on it as well. So, and this is where decisions are made. And then what's really important is the request from primary care is that you are requesting somebody to be on a cancer pathway. And the anxiety at that point is heightened significantly. And what's really important is to actually give the patient information back to the patient that they do not have cancer. So what we're really trying to aim for is a same-day endoscopic assessment to say, and a report given back to the patient to say, you do not have cancer. Because actually not knowing you've got cancer is really important as well. And this is part of a faster diagnostic service. They have reflux, they have benign disease, they may be waiting for biopsies for the eosinophilic esophagitis, but then it actually gets a diagnosis for them rather than just a not cancer. So that's really what we're trying to aspire to. And this system has really been hovering around in the background while COVID, we've been trying to sort out the post-pandemic recovery systems. But this is what we're trying to achieve now. And then the patients will then go on to the pathway that I described. However, the battle with esophageal cancer and gastric cancer is that when you have operable disease, is that, unfortunately, that means that your 5-year survival is still only 50%. And that includes neoadjuvant chemotherapy. It includes a large esophageal gastrectomy, which involves a thoracotomy, an abdominal wound, 3 to 6 months recovery. And the chance of recurrence is still there. So despite all these efforts, what can we do to try and help? So what about I don't want an endoscopy? we've had local research done by one of our previous BMed Sci students who did a great study on looking at gastroscopy and knowing that people that actually don't get pain with a gastroscopy, but they do get distress. And a distress score out of 10, probably about 4 out of 10, as opposed to a colonoscopy, which can be more painful, but actually more relaxed because pain's okay, but this kind of idea of claustrophobia can be quite difficult. Despite that, we've had subsequent research done by another thing saying, well, despite all that, 9 out of 10 people would say, I don't mind recommending that to a friend. But is it there's a hesitancy for people to think, oh, I've got some pain, I'm not going to go see it because they'll make me have one of them gastroscopies. So what can we do that's different? Well, let's make an endoscopy easier. Transnasal endoscopy is available now. Endoscopes are about 1 centimetre, about a little finger sort of size. We do have an endoscope now that's about 5.8 millimetres, which goes through your nose. Now, why is that any easier? Well, actually, the tolerance studies are a lot better. And we do have it available now. You can scan this QR code for the patient information leaflet, which will be available. And I think that's muted, isn't it? Fantastic. So this is me performing a transnasal endoscopy on a gentleman that had quite a significant reflux, and he was coming back for a recheck. We was ready to sedate him if he wanted it, but as you can see, I'm passing a tube there through the nose, and I'm actually talking to him, and he's talking to me because I'm not actually going there. So there's the turbinane as you go past the middle and lower turbinane as you go round, and because you're not touching the back of the tongue, it's not the back of the throat that makes you retch, it's the back of the tongue. You're able just to pass this straight past into the hypopharynx without any problems. There's not a single retch there. There's not a cough or anything. And as you say, and as you go past, you can see his vocal cords moving because I'm asking, is he okay? And he's talking to me. So the idea is that we can do this with a much better tolerated low sedation because this cohort that we're talking about is the working age group who don't want to have time off work because they're too busy to attend. They don't want sedation because they're too busy to attend, and they will retch a lot. And as you can see, it's the definition now is fantastic. How about a barium swallow? We used barium swallow. It came to full force when the pandemic hit and endoscopy services ceased for dysphagia as a alternative. It is second place, but it is effective, but it has to be dysphagia. Do not use it to look at the stomach. It's not perfect. If symptoms were ongoing, you definitely want to do all the tests, but we were using it very effectively as a screening tool for dysphagia, looking for cancer. It can be requested by primary care, but please don't use it to look at the stomach because it just doesn't open. They give Carbex to try and expand, and you do get good reports sometimes, but it's just not a good test. And neither CT isn't a good test to look at the stomach. What about upper GI capsule? We've had that mentioned as well earlier at the talk. It is good at looking for Barrett's. It can't sample. It's not for dysphagia because obviously you've got to swallow a pill. So this is another one of our BMed Sci students who was happily taking in swallowing a capsule endoscopy to have a look at the lower esophagus. So here's his, this is a video that was given to me by Professor McAlinden, who's currently in Hungary learning how to do more of these sort of procedures. And as you can see, you can swallow a capsule down and it can have a really good examination of the esophagus. Here it goes through. There's the gastroesophageal junction, and you have to lay on your side, of course, and he's having a terrible time of course, with the capsule doing all the work for him. So yeah, I'll let you choose which one you want. Esophageal cancer's on the rise. It's adenocarcinoma that came up. Big hit up till 2000, about 2010, but it slowly started to steady off. Gastric cancer's coming down, but it's the adenocarcinoma that's the problem. Squamous cell cancer's going down. And why is adenocarcinoma going up? It's probably because of the cohort of our country, which is starting to become overweight, more reflux. Despite that, there has been a lot of talk about whether we should just screen reflux, and as Kumar mentioned in the last talk, we should avoid screening reflux with endoscopy, all patients with reflux with endoscopy. And NICE guidance usually says over 50, Caucasian, male, and overweight. So this chap here, and I've just put the cigarette in his mouth to complete the mess that he's in. But however, it's not justifiable, and the cost is not justifiable. And I suppose our capacity may be against trying to screen everyone with esophagus to look for these patients with adenocarcinoma that will develop Barrett's. So how about cytosponge? We've mentioned it already. Again, if you want to go to that QR code, that'll give you a picture of the actual and some more information from the Cancer Research UK site and a video of the patient swallowing one. But ultimately, it's a gelatin capsule that's swallowed on a string, stays down there for 5 minutes, and you pull it out, put it in a pot and send it off. And it's been really well trialled, and it's basically well tolerated. 19 out of 20 people can swallow it. There's very low any complication risk with it at all. And if you actually look at the study done in primary care with 6,000 patients, well, over 6,000 patients in each arm, which is basically, we'll just leave you as you are. These are patients over 50 on PPI, so a high prevalent group. You could almost argue you should have a scope. They showed that you could actually screen people with a cytosponge effectively. About 2,000 patients will take up a cytosponge if offered, and of that you probably get about 10% will come back with a positive and they can get scoped. What's interesting is that they find about half the patients you do a cytosponge on will actually have Barrett's esophagus when it's positive, and they will pick up cancers and early cancers. And I'm interested in this is because I deal with early cancer removal, and if we said they're the patients who will survive and change this current shift in care, which is esophageal cancer, only has a 50% 5-year survival. Interestingly, though, the problem with cytosponge currently is the cost. If you look at those two arms, which is scope everybody, or use cytosponge and then scope them, in those patients, there's nearly 2,000 patients. Just scope everyone was about 7,000 to 720,000 versus if you employ the cytosponge in the pathway, it drops it to about 620,000 for 2,000 patients. So it's difficult at the moment, and but it's working through, and there's a lot of interest about early detection, but it's a case of financing that early detection at the moment. Because if you do find it early, and you do find one of those T1 cancers that we're talking about, this, for example, is a T1 cancer. It's that white spot at 3 o'clock. We do 1 or 2 of these a month where we were able to go down with an endoscope, the patient's under conscious sedation, we're able to remove the tumour by using an endoscopic method of aspirating the tumour into the end of the endoscopic cap and cutting it off. There's risk with it, with bleeding and so forth, but the actual survival curve of patients who were treated for T1 cancer endoscopically is exactly the same as age-matched controls. So the recurrence is so low now, and what we're able to do is remove that with the snare at the time of the endoscopy to cure that patient, and that's because it's been found early. And these are the patients that we're desperate to find. These are the patients who get picked up with Barrett's surveillance, and patients who get picked up with very cautious and close endoscopy, and that's what endoscopy is for. So with cytosponge, hopefully might start changing our early detection rate and actually change it along with obviously a faster service. Just going to snip that off and then move on. So what we're able to do is when we remove the area, is then send that off to histology, and just like you get a cancer resection, is you can say this is a cancer that's been cured and let the patient know, and then go on to prevent any further problems from the Barrett's by treating their Barrett's esophagus with radiofrequency ablation, which we offer in Sheffield for the region, by burning it away. So in conclusion, it's got a poor prognosis. It's a complex pathway. If any of your patients are on that pathway, they need an awful lot of support. We have a lot of cancer nurse specialists that do that. The faster diagnostic service is being implemented to try and just get things going for their patients earlier, to make sure that if there is a cancer diagnosis there, the next hurdles, there's a significant number of hurdles that they're going to embark upon. But also at the same time is trying to get information back to your patients to let them know that they do not have cancer. And it's the late presentation is the problem at the moment. And I think early detection can be cured endoscopically. So I think easier access to endoscopic or esophageal or gastric investigations, I think really need to take off to really start changing the outcome of this cancer. So rather not just a faster diagnostic service, but a more accurate and earlier diagnostic services required from us. Thank you.